Amitabh is an economist and professor of public policy at the Kennedy School at Harvard. And he's also a research fellow at NBER and IZA in Bonn, and he's done most of his research on productivity and cost growth in healthcare, and on racial disparities in healthcare. And he's been supported by all the people you can think of who would normally support things like that, and a few who wouldn't, but did in this case. And he's been published by all the places that one should be published, too. The American Economic Review, Journal of Political Economy, Economic Letters, New England Journal of Medicine, you name it, he's there. And the most important thing, though, is that he's quoted frequently in the New York Times. This is the measure of the Kennedy School faculty these days. So he's going to chair the session, and I'm going to turn it over to him.
Thank you, Sandy. I promised to get us all out on time. Thank you for that introduction, Sandy. So today is the 11-month birthday of the Affordable Care Act. So here is the president signing the Affordable Care Act in the East Room of the White House. And this is a very special moment for everybody in America. This was literally, it wasn't, I mean, people say, well, the Democrats have been working on this for a year and a half. That's not true. We've been working on this for decades. What I thought was really interesting about this photograph, and this is a theme that I'll return to in my comments, is that standing right next to the president is 11-year-old Marcellus Owens of Seattle, who became an advocate for healthcare reform after his mother died because of lack of health insurance. And so I think this is a really powerful story, and a story that I think the president didn't push hard enough when he was doing advocacy for the Affordable Care Act. It remains to be seen whether this act is affordable, caring, or as some would like to have it, maybe not even an act in the first place. So hopefully that's one of the things that this panel will get into. When the president signed this piece of legislation last year, here's what he said. He said, "The bill I'm signing will set in motion reforms that generations of Americans have fought for and marched for and hungered to see. Today we are affirming that essential truth, a truth every generation is called to rediscover for itself, that we are not a nation that scales back its aspirations." Very, very powerful words. On the same day, another person by the name of Jim Boner said, "This is a somber day for American people. By signing this bill, President Obama is abandoning our founding principle that government governs best when it governs least." And soon after the passage of this reform, we now have something called a bill that just passed the House, which is titled Repealing the Job-Killing Healthcare Law Act, and it passed the House earlier this year, which is another thing I want to talk about, hopefully this afternoon. What's more problematic for people who are advocates of this legislation is that attorney generals in more than 12 states have passed lawsuits contending that the measure is unconstitutional. And I hope that, Paul, you'll have something to say about that later today. And other Republican congressmen have said that they will use every procedural weapon available to them to punch as many holes as possible into this legislation so that even if the individual mandate is not repealed, funding for the Affordable Care Act will be severely constrained. So we want to understand whether that will actually impede the implementation of the Affordable Care Act. What does it mean for the president's statement? I never know what to make of all these things, and so I threw up my hands in the air. But this particular exhibit really appealed to me. So I saw the sign at a rally in Washington that some of you probably attended. And I'm hoping that today's panel can make much more sense of the key issues than any one of us could do individually. So that's sort of the theme of this afternoon. I think this is where we'd like to go in some sense, and maybe Theda and Paul can help us think this through. So we have this afternoon two rock stars of healthcare policy, Paul Starr and Theda Skocpol. Paul Starr is a professor of sociology and public affairs at Princeton University. He holds the Stewart Chair of Communications and Public Affairs at the Woodrow Wilson School. He has received, as you all know, the Pulitzer Prize and Bancroft Prize for the social transformation of American medicine. In 2005, Paul won the Goldsmith Prize for the creation of the media. His most recent book, Freedom's Power on the History and Promise of Liberalism, is now available in paperback. Paul, I read your book as an undergraduate in the 1990s. That was almost 20 years ago. I have 2 copies of it, one at home and one at work. And I find myself reaching out for it as often today as I did back when I was an undergraduate. Maybe that tells you about how little I actually learned. But this is a tremendous book for the graduate students in the room who have not read it. Theda Skocpol is the Victor Thomas Professor of Government and Sociology here at Harvard. She has served as Dean of the Graduate School and as Director of the Center for American Political Studies. In 2007, Theda was awarded the Johan Skite Prize in Political Science, which is bestowed by the Skite Foundation in Sweden. Theda's work covers an unusually broad spectrum of topics, and the number of books that she has written is really extraordinary. She wrote States and Social Revolutions in 1979, Protecting Soldiers and Mothers, The Political Origins of Social Policy in the United States in 1992. She is an author of the definitive book on President Clinton's healthcare policy called Boomerang. And most recently, she wrote Healthcare Reform and American Politics, What Everyone Needs to Know. I have my copy right here, and I'm going to talk about this in class tomorrow, so maybe you'll autograph my book before we get done. I got to tell you, when you read this book, I read many books on healthcare policy, but I've never read a book on healthcare policy where right in the middle of the book come all these references about, the Vikings and Brent Favre, and like he's throwing an interception that gets caught by, the Saints, who go on to do all kinds of glorious things. So this is the reason, if you know nothing about healthcare, nothing about football, like someone like me, this is where you need to go. But let's get started. Paul, welcome back to Harvard. The floor is yours. And thank you for doing this.
Okay. Well, thank you. It's good to be back and to see many familiar faces. A year ago, with the passage of the Affordable Care Act, it seemed as though this country had reached some kind of resolution in this long and rancorous conflict over health care in this country. But whether the legislation really resolved anything at all seems unclear. The conflict goes on, and it's as bitter as ever. If the Affordable Care Act is carried out in 2014, exactly as planned, I will be delighted, and I will also be surprised. It's not that I expect the Republicans in the current Congress to succeed in repealing the law, or even to do that much damage to it, although I think they're capable of doing a great deal of damage to the country. But in the next few years, the law is going to be at risk in more than one way and for more than one reason. First, of course, the Supreme Court may overturn the individual mandate, and with it substantial parts, if not all of the legislation. Several weeks ago, Lawrence Tribe wrote in the New York Times that the Supreme Court was certain to uphold the law and that it was an insult to the integrity and intelligence of Justices Scalia and Roberts to think that they might contradict previous rulings because of political considerations. Well, that seemed to me to be an artful strategy of argument rather than a confident prediction about how they will vote. The law may, in fact, stand or fall on the opinion of a single justice, Anthony Kennedy. The second risk to the Affordable Care Act is that in 2012, the Republicans, of course, may win both the presidency and Congress, and early the following year repeal the law's major provisions expanding coverage, which are scheduled to go into effect a year later, in January 2014. Now, how much the Republicans can do in 2013, if indeed they do win the election, would depend on the exact makeup of the Senate and how far they were from the 60 votes needed to have a filibuster-proof supermajority. But they can pass a budget reconciliation bill requiring only 50 votes, and thereby undo the affordability subsidies and other financing provisions and render the law's expansion of coverage a dead letter. They could also perhaps postpone it indefinitely, which might be easier to do. And because the law gives the Secretary of Health and Human Services so much discretionary power, a new administration could revise or reverse many of the regulatory policies instituted under Obama, even if some of the law remains on the books. A third possibility is that if Obama is indeed reelected, the Republicans may win control of the Senate as well as the House in 2012 and use their control of Congress to force a major renegotiation of health care reform. So if you tell me how Justice Kennedy will vote on the mandate and who will win the 2012 election, we will have a good idea of whether the Affordable Care Act survives. But rather than speculate on those unknowns, the more interesting questions concern the possibilities for revising the law short of total repeal. Now, just to be clear, I don't expect the current Republican House to vote for any revisions of the law that would reduce its legal or political vulnerability. If Democrats still controlled the House, they could replace the mandate with alternative policies if the court declares the mandate unconstitutional. That opportunity has been lost. But there may still be room for amendments, even in the short run, and there could be a good deal more room in the event of divided government after 2012. There is also a question, looking ahead to the 2012 election, about how President Obama and the Democrats should position themselves on various possible changes to the law. Now, while the law was still under debate in Congress, I argued first in an article in the American Prospect that was called Averting a Healthcare Backlash, and then in an op-ed in the New York Times, as well as in private conversations with Henry Waxman and other members of Congress and the administration. I argued that the administration should allow, that the law should allow individuals to opt out of the mandate as long as it didn't allow them to opt back in whenever they wanted and obtain subsidized insurance whenever they wanted. Now, public opinion polls showed the mandate to be the one distinctly unpopular provision of the law. As I wrote in the prospect, the mandate communicates the wrong message about a program that is supposed to help people without insurance, not penalize them. And many people simply do not understand why the government should fine them for failing to purchase health insurance when it does not require them to buy other products. And to be sure, the mandate comes along with subsidies for low-income people to buy coverage, and the law exempts from the mandate anyone with an income below the tax filing threshold and anyone for whom health insurance, even with the subsidies, would still cost more than 8% of income. But most people don't understand how the law works, and many of them don't trust the government. What's especially tragic is that some people who would benefit from the law see it as a threat. On a call-in radio show when I was defending the Affordable Care Act, a woman called in and said, I don't have the money to pay for health insurance. You might as well just cart me off to jail. The individual mandate does have a legitimate policy rationale. The purpose is to prevent free riding and opportunism, to prevent people who could pay for insurance from buying insurance only when they get sick. Any insurance system that allowed people to buy insurance on the way to the hospital and then to stop paying for it when they got home would be ridiculously expensive. But the mandate is not the only way to prevent opportunism. And moreover, the mandate in the Affordable Care Act is not really a mandate in the common meaning of the word, because the fines are so low, and the law actually includes no provisions for enforcing them. People don't realize this. What happens if you don't buy insurance? Well, under the law, you're supposed to pay a penalty on your taxes. What happens if you don't pay this penalty? Actually, nothing. Well, you may get a letter from the IRS, but the IRS cannot garnish your wages. It cannot put a lien on your property, and there are no criminal penalties for refusing to pay the penalty. That woman on the call-in show didn't have to worry. She's not going to have to go to jail. Nobody is. The law ultimately relies on a norm of law-abidingness to obtain compliance. Now that, I think, actually worked reasonably well in Massachusetts, although the fines in Massachusetts are actually higher than they are in the federal law. But here you had overwhelming support. Business, the Boston Red Sox, all these ads that were supporting the idea that it was time for everybody to get insurance, and you also had, of course, a much higher level of employer-provided coverage in this state. You started out with a much higher level of coverage than in many parts of the country where we have 20–25% uninsured with much, much lower levels of employer-provided coverage. It's very unlikely that we'll get anything like the level of compliance elsewhere, especially because there might be organized resistance at the time it goes into effect. So extrapolating from Massachusetts, using the data in Massachusetts to project to the country, no, that doesn't make any sense to me at all. So paradoxically, while the mandate looks like a huge expansion of federal power, it is really an expression of congressional timidity. Congress was afraid to put strong enforcement provisions into the law because of the potential backlash, but it got the backlash anyway. It's got the worst of both worlds. A poorly enforced law, along with the impression that it's excessive power of the federal government. Now, my alternative to the mandate is both more libertarian and more tough-minded. Now, before my progressive friends hear out the entire proposal, they often jump to the conclusion that it would lead to more people remaining uninsured. I think that's because they haven't thought through what the law currently says and the fact that actually millions of people will remain uninsured under the current law. And it's not necessarily true that this alternative, which I'm about to explain, will leave more people uninsured. The behavioral economist Richard Thaler recently wrote about my proposal that it should do just as well as the current mandate in expanding insurance coverage. So here's how it goes. If you don't want to buy coverage, you can opt out of the mandate without penalty by signing a form on your tax return, waiving your right for a period of 5 years to 3 benefits under the law: the insurance subsidies, use of the insurance exchanges, and guaranteed access to a policy with no pre-existing condition exclusions. The current law creates an incentive to purchase insurance by imposing a fine, though it doesn't enforce it. This 5-year opt-out creates an incentive to purchase insurance by withholding future benefits and forcing people to consider their needs 5 years into the future. Now, my proposal also offers one other option. In fact, it's the default option if you do neither. If you don't fill out that form and you don't buy insurance, or suppose you just want to keep your options open from year to year. Okay. In that case, as under the current law, you would pay a penalty each year on your taxes, but it would be a substantially higher penalty than the one in the law, and it would be enforced. So that's the idea. More libertarian, there's an opt-out, but also more tough-minded, there are tougher penalties in the default case when you do nothing. Now, just recently, Congressman Peter DeFazio introduced a bill in the House that is similar to what I proposed. It would also allow an individual opt-out from the mandate for a fixed period. It's 3 years in his bill. And under his proposal, people would file an affidavit of personal responsibility with the insurance exchange, acknowledging that by doing so, they would become ineligible not only for the benefits under the Affordable Care Act, but also for Medicaid and for protections under federal bankruptcy law. So he's a lot tougher in that respect. Now, I don't think the latter two provisions are necessary or advisable because they're likely to hit a lot of poor people. Anyone who qualifies for Medicaid is already exempt from the mandate. Under DeFazio's proposal, some low-income people would sign away their rights to Medicaid in the mistaken impression that the mandate applies to them. But I hope DeFazio's proposal, this bill, opens up the discussion about the mandate, about other alternatives to the mandate. So one other option, one other alternative to the mandate, is to raise premiums month by month or from open enrollment period to open enrollment period for people who delayed obtaining insurance. Now, that might work well enough for a while, but if the premiums keep escalating, they'd hit levels that effectively bar people from obtaining coverage. Whereas I'd give people the option of getting back in at standard rates at the end of a 5-year opt-out. But it might be possible to combine several of these different alternatives that I'm describing. Okay, another proposal to modify the law in the interest, in this case, of state flexibility comes from your senator, Republican Scott Brown, and from Democrat Ron Wyden of Oregon. And it's a one-sentence amendment to the law, moving up from 2017 to 2014, the date when states can obtain waivers from any of the law's specific provisions, as long as they provide as comprehensive coverage to as many people as the law would otherwise insure at no greater cost to the federal government. This provision to allow states to opt out, to give them waivers, came from, or at least in response to, an unlikely pair of senators. It came in response to Bernie Sanders, who wants states to be able to set up single-payer systems, and to Orrin Hatch, who wants to be able to do more market-oriented alternatives. Some people in Congress refer to it as the Sanders-Hatch provision of the law. In practice, of course, far more states would move in Hatch's direction than Sanders, and it's unlikely they would, in fact, be able to offer as comprehensive coverage to as many people. By moving that state opt-out up to 2014, as this Wyden-Brown amendment calls for, it could really throw implementation of the law at the state level into a wide-open free-for-all. And I'm not eager to see that happen. The current law already has a lot of alternatives that states need to work through. But Wyden-Brown has a lot of support, and it conceivably could pass Congress. And it's conceivable that President Obama could sign it. Even if it does, however, the Secretary of HHS would still have the authority to determine whether to grant waivers. And if Obama is reelected, that authority should keep in check tendencies that would otherwise undermine the purposes of reform. But combine Wyden-Brown with a Republican administration in the future, and the results could be very different. Still, if Wyden-Brown is the alternative to total repeal, I'd certainly take Wyden-Brown. In retrospect, instead of a wide-open waiver enabling states to drop any and all provisions of the Affordable Care Act, I regret that the law didn't have a waiver specifically on the issue of the mandate. And really what it should have done, this would have made it bulletproof constitutionally. What it should have done was to offer the states a menu of alternatives that they could adopt to limit free riding, which could have included, as one of the possibilities, an individual mandate, a long-term opt-out, rising premiums for those who failed to insure initially, a whole series of different options. In that case, any individual mandate would have been enacted at the state level, and there would have been no grounds for going into federal court to contest the constitutionality of the law. The developments in the courts and in politics are interacting with each other now. The court decisions in Virginia and Florida overturning the mandate have not only fortified the resistance, the political resistance to the law, they have focused public attention on this least popular provision of health care reform. And according to polls, many people are ambivalent about the law. They like some things, they don't like others. They especially don't like the mandate. And the focus on the battle, the legal battle on the mandate, is, I think, priming public opinion. It's focusing public opinion on the aspect of the law that is the least popular. So when people are asked, are you in favor of repealing the law, this is the thing that may come to mind first. And it may be, I think, really distorting what is otherwise could be a much more favorable political situation for the bill. Now, the influences also go the other way. Judges do respond to the election returns. Despite Professor Tribe's confidence about the Supreme Court, the conservative justices may be emboldened by Republican electoral victories this past November. The 1937 Supreme Court upholding Social Security came right after Roosevelt won re-election. The 2010 congressional elections pushed the court in the opposite direction. There may also be a tricky interaction between the legal developments and the next presidential election. It's possible we could have a Supreme Court decision right in the middle of that election. It could be devastating. I mean, if it's a decision against the Affordable Care Act, it could really have a very severe effect on Obama's candidacy. I think also Obama doesn't want to say anything about alternatives to the mandate that could in some way undermine the case that the Solicitor General is going to have to make to the court. And I think that may now be inhibiting frank discussion by the president about alternatives. But looking ahead to the 2012 election, the president and other Democrats have got to be thinking through the alternatives that they might want to support, given the fact that even if the mandate is constitutionally upheld, it's still the most politically unpopular part of the law. And there are going to be a lot of Democrats, I think, looking for an alternative. You may remember back in 2008 there was a candidate for the Democratic nomination who opposed the individual mandate. Oh, in fact, during the Pennsylvania primary, that candidate ran a campaign ad which said the following about his opponent. What's she not telling you about her health care plan? It forces everyone to buy insurance, even if they can't afford it. And you'll pay a penalty if you don't. That candidate, of course, was Barack Obama. That ad against Hillary Clinton was not one of the moral highlights of his campaign. A little earlier in Massachusetts, of course, you had a governor who succeeded in enacting an individual mandate. And in June 2005, Mitt Romney called the individual mandate, I'm quoting him, the ultimate conservative idea, which is that people have responsibility for their own care and they don't look to government. No more free riding, if you will, where an individual says, I'm not going to pay even though I can afford it. That's all a quote from Mitt Romney when he was introducing that idea. We could, in 2012, if Mitt Romney is the Republican nominee, have a situation where the two candidates were taking the reverse position from the one that each took a few years earlier, where Romney's the candidate of the party that denounces the mandate, and Obama is defending it. Stranger things have happened in politics. Finally, suppose we see the scenario I mentioned at the beginning, in which Obama wins re-election, but Republicans take the Senate as well as the House. In 2012, more than twice as many Democratic as Republican seats in the Senate come up for re-election. So a Republican takeover is entirely plausible, even if Obama wins a second term. So in that case, I really think we'd have a significant renegotiation of the law. And if Republicans could claim victory by eliminating the mandate while leaving most of the rest of the law in place, that would be a tremendous way of giving closure to this fight. In the long run, there needs to be some settlement between the two parties. Even if it survives in court, the Affordable Care Act will be unstable as long as one of our two major parties is committed to reversing it. So figuring out what concessions might be enough to reconcile Republicans to the reforms is crucial. But perhaps the Republicans will overreach this year in the budget battle the way they did in 1995, allowing Obama to sweep to re-election as Clinton did in 1996. And perhaps under those circumstances, the Democrats will hold the Senate and the law will go into effect in 2014 as planned. And the federal government will be left with the lesser, though not insignificant, problem of dealing with a group of recalcitrant red states, the Tea Party dead-enders, that either refuse to implement the law at all or implement it maliciously so that it's a mess. Now that is actually the rosy scenario for 2014. But as I said in an email when we were planning this session, I will leave the sunshine to Theda.
Yeah, well, I think on balance, I am going to perform the role of the optimist here. But I should say that Paul and I have a long history of thinking about healthcare reform episodes, and as you heard, he's a policy designer. That's what he was, one of the leading policy designers in the Clinton episode of 1993-94. I am an analyst of the politics and would not presume to try to design an ideal healthcare policy. And I will say that I don't believe that we are in a conjuncture right now where policy design is going to be particularly relevant, policy design going forward, is going to be particularly relevant to the national politics of health reform. I want to back up and say just a little bit about why the Affordable Care Act that was signed into law on March 23rd, 2010 is a remarkable milestone in American social provision. It is, in my opinion, even though I was disappointed as many were at the omission of this or that provision, it is comparable in importance to the Social Security Act of 1935 and to the expansion of Medicare in 1965. And why is it so important? Well, the law does three big things, and I don't think the mandate is anything like one of the big things it does. it sets up new rules of the game for the private insurance industry, which says that they will continue to be able to make profits, but will have to do so by expanding the ranks of the patients they serve and doing a better job, quality and cost efficiency in serving those patients. You can bundle up a lot of the insurance regulations under that. I like to say it'll make it more like the NFL, at least the old NFL, than Major League Baseball. So it's a new set of rules for the private insurance industry. Secondly, it is a vast expansion of Medicaid and a huge set of subsidies for lower income and lower middle income Americans to make insurance available and affordable, either available through an expansion of Medicaid to higher into the income ranks of the lower income population and more consistently across the states, and the subsidies to enable purchases on the private exchange for those who don't have employer insurance. That's the big bucks in this law, and that is what much of the fight really is about, and why if the fight about the mandate went away, the hatred of the law would still be there in the attempt to undo it. Finally, it's a series of expansions and improvements in Medicare, which are not insignificant, including new cost control measures for Medicare and beyond, encouragement of experiments in better care, and of course improvement in the Medicare beneficiary benefit. The individual mandate, as Paul pointed out, is a toothless tiger and doesn't really matter very much. The final part of the law that is crucial is that it mandates states to set up regulated exchanges on which private insurance policies will be compared and sold to businesses, small businesses and citizens that often benefit from tax breaks to do so. And that ended up being at the state level rather than at the national level, as the Obama administration wanted, because of course the end game for the passing of this law required the Senate version from 2009 to be passed with only modifications in taxes and subsidies, but not regulatory modifications. That was the rule of the game to get this thing eked through in March of 2010. Now, the law, as David Lienhardt of the New York Times has pointed out, is one of the most redistributive pieces of social legislation to be enacted. And I think a lot of liberals don't know that. A lot of liberals are fixated on the idea that the public option, which was a puny, circumscribed, toothless tiger by the time it eked its way into the House version of the legislation. It never had a chance, no matter how emasculated it was in the Senate. So liberals mourn the public option. But the real emphasis in this law is in the expansion of subsidies in Medicaid, which is going to finally enable the big losers, the younger families, the people who work for smaller businesses, the people with modest incomes or lower incomes who are above the Medicaid cutoff and below the, or left out of private employer insurance, to afford insurance. That is redistributive in two major ways. The law pays for that expansion of coverage mainly through taxes and fees on businesses and on the wealthy, including wealthy elderly Medicare recipients. So it's redistributive socioeconomically. It's equality enhancing in a polity which has been doing all it can to increase socioeconomic inequality for the last several decades. It is also redistributive by age. It squeezes a bit, and I really mean a bit, Medicare to help find some of the resources to help primarily younger and, of course, more likely to be black and brown people. So the controversies about the enactment of this law and the bitter conflicts that are indeed going to continue for the 5 years it takes to get to on paper full implementation, and probably another 5 to 10 years after that. The conflicts are mainly about these redistributive features and the enormous resistance that privileged people and well-established interests, not all of whom are conservative. Some of the well-established interests were trade unions. Some were the nonprofits that refused to be taxed to pay for expansion of coverage to nonprofits run by good liberals who tell us they love humanity. The resistance that established interests of all kinds and privileged people can put up in a budget-constrained situation, remember the United States inherited huge deficits, to a redistributive law of this kind. The battle was over how to squeeze out the resources to pay for the inclusion of most Americans in the private insurance market or the expanded public programs. And a lot of the conservative anger and resistance is well organized, well funded, and very much coming from governors of the mainly GOP-controlled states that have large uninsured populations right now and are going to have to deal with those insured populations going forward under this law, and many of the business interests that resist the fairly modest taxes and fees that have been imposed to try to pay for this law and to make it coded by the Congressional Budget Office as something that would save money over time while expanding coverage. So I just wanted to say that about the nature of the law. I won't go through, I mean, you can definitely read the book to find out, I hope, an entertaining and clear analysis of the political battles that led to this, including the surprising turn after Scott Brown was elected in a more liberal direction, as it finally became clear that you couldn't get a single Republican to come on board. The Democrats finally snapped into it and came up with a version of the law that was slightly more redistributive than what was there before. That enabled the law to pass, but of course it set up many of the ongoing battles going forward. Now, I'm just going to express a quick opinion. I think the best political science research suggests that votes for the Affordable Care Act, after it had been demonized in a year-long, protracted, ugly congressional sausage-making process, resulted in maybe 10 more seats lost for the Democrats in the House elections. The big things in the House election, which were indeed a huge reaction against the Democrats, were the economy and probably votes on cap and trade as well in the House of Representatives. And the fact that the Tea Party, which is predominantly an organization of angry, older white people, mobilized people to a higher level of intensity and a more GOP margin in a midterm election where 40% of the voters went to the polls, as opposed to a presidential year when about 60% go to the polls. And that's important in understanding the difference between 2008 and 2010. It's also important in understanding what's going to happen in 2012. Now, it's not unusual for a major piece of legislation like this, particularly one that's redistributive, one that steps on the toes of established business interests and healthcare interests, to be hotly contested. And we should not expect that the mere signing of the law in that lovely picture was anything but the beginning of the next phase. So what's going to happen? Well, I'm not a predictor, but I'll tell you how I think about it. It is a long process until the concrete delivery of benefits to low and lower middle income people becomes obvious. Many Americans probably do think that the mandate means they're going to have to buy private insurance now rather than after it's affordable for them. Although I'm not persuaded that the mandate is the reason why popular opinion remains ambivalent. The picture of popular opinion is that about half say they like the law globally, about half say they don't like the law globally. That hasn't changed significantly in the whole time since it was enacted. But if you ask people about the specific provisions, very large majorities, like the new insurance rules, the subsidies, the aid even for the poor, everything except the mandate polls well. So that means that as the specifics become more real to people, signing up the kids till 26. I mean, you go into a cafe, people were talking about that. It's real. Or the Medicare rebate checks for those in the donut hole. As it becomes more real, or they know somebody for whom it's become more real, focus shifts a bit more to what might be lost if this were repealed. And the latest polling on repeal suggests that if you ask the question in something other than that highly global way, if you ask people, should we stick with it and fix it? Should we wait and see? Should we make it more generous? The number who really want to go with the GOP kill the bill approach is only about 25 to 30%. Now that happens to be more than half of the Republican base. So that's why we're not going to see any playing ball from the Republican Party at all on anything except the tax relief for small business, which I believe is happening. They're going to change the reporting requirement for small business. But I don't think any of the improvements that Paul or anyone else can dream up have any chance with this Republican Party in the next 2 years, or probably after 2012. So what should we think about the future of the Affordable Care Act? Let me just run through a few possibilities. Will the courts overrule it? That's the favorite topic of discussion of media pundits and professors. It's because it's so easy to speculate on. You know, the issues are, you can read opinions, you can, we're now up to 3 district judges, all appointed by Democrats who've said it's constitutional, and 2 appointed by Republicans who've said it isn't. And we can speculate about, you know, Scalia and Roberts and Kennedy. I'll speculate too, but here's how I'm going to speculate about it. Recently, apparently, Justice Ginsburg said, we're not going to be in any hurry to take this up. I think that's what we can expect. I think the Supreme Court of the United States is going to take its time. And judges can always take all the time they want. They're in a position to stall. Think about it from their rational perspective. It's highly charged politically. In a country that is more polarized by the day, both in Washington, D.C. and across the country. A Supreme Court of the United States that has waded into one politically charged thing after another, causing the beginning of some mobilization on the left questioning the legitimacy of some of the justices. I don't know what's in Justice Roberts' mind, but if I were him, I'd stall. Because if Barack Obama is re-elected president by a substantial margin, that's one situation for the court to face. If he's not re-elected, they can deliver the coup de grace very quickly. So my prediction is stalling, allowing the thing to percolate up through the district courts, the appeals courts, we'll get colorful opinions. The judiciary is incredibly politicized right now, and it'll be very theatrical, lots of articles in the New York Times, lots of CNN, lots of Fox News, but it'll be all political theater until after we see the big Megillah here, which is whether Barack Obama is reelected in 2012. Now, I think it's highly likely that the Senate will pass into Republican hands for the reasons Paul said. There are just so many seats up, but the Senate is not exactly, for the Democrats, the Senate is not exactly a decisive institution that moves clearly in one way or the other. And the other variable in 2012 will be how many seats the Democrats regain in the House of Representatives. If they come close to taking back control, that will send one political message to the political class. If they don't, or even lose ground, that will be something else. So I agree with Paul's point that the politics in the electoral and public opinion sphere, particularly electoral, will interact with what the courts do. But I think all the incentives are for the Supreme Court to take its time so that it can see what it is entering into politically as well as intellectually. That means that in the intervening period, two things are going to happen that are vital to this law. One is how the parties position themselves going into the 2012 elections. It may be that the Democrats originally hoped, they certainly acted as if they hoped, that they would never actually have to explain this law to people. The way I just explained it a little while ago, they don't ever do that. They may not have thought that they would have to fight much of the next presidential election on this law. But I think fate has determined that they will. I think President Obama will have to defend and articulate the defense of the benefits forthcoming in this law, as well as those already felt by people. And it'll be interesting on the other side, because if Mitt Romney is probably the best Republican nominee in the sense of having a chance to reach to the middle, but how in the world is he going to attack Obamacare when it is Romneycare? That'll be very, very entertaining, and I'm hoping for that outcome. I think that'll be a really interesting election, and I don't think the Republicans will get far. But I also don't think, since I think the Tea Party movement and the intense mobilization of free market billionaire conservatives that's going on in the Republican Party, I think they're determined not to let a nominee emerge for major party offices in the Republican Party that will compromise on any of these things. And I think it's going to be hard for Romney to win the nomination in the Republican Party. But in any event, this law will be part of the debate in 2012 in both the congressional and the presidential election. Meanwhile, while all of this theater is going on, you know, the court decisions and the speculation about the court and the colorful stuff going on in the elections, the real story of affordable care is the steady march of implementation that is going on. So let me conclude by just saying two things about that. Kathleen Sebelius is a remarkably savvy and determined, tough-minded administrator. Decisions have been made to place the supervision of implementation of much of affordable care in parts of Health and Human Services and the Center for Medicare and Medicaid Services that are savvy and expert. She managed a process of negotiation with state insurance commissioners that resulted in a pretty good version of the medical loss ratio, the rule that insurance companies have to pay use most of their premiums on actual medical care, which is crucial to the cost control features of this law and to probably to its effectiveness with citizens ultimately. She has put in place rules about insurance premium increases, and she stepped on Medicare Advantage private Medicare plans that were charging too much for too little. So she's moving forward steadily. Nobody's going to stop her. Congress is not going to be able to do anything more than to drag her into very interesting hearings, which I suspect she'll do just fine in those hearings. The other part of the implementation is in the states. From the perspective of liberal received wisdom, it's always bad to have a lot of a public policy implemented by the states rather than the federal government. And Larry and I were doing interviews in Washington back in around the end of 2009, and the White House people wanted us to go home and write op-eds about how important it was to have a national exchange rather than a state exchange, because they felt they would be able to control the rules of the game. Well, in the end, you know, there was only one way to get this law passed, and we couldn't tweak the individual mandate. We couldn't tweak anything. After Scott Brown was elected, it was either the Senate version with a few tax changes or nothing at all. It was very dire. So state-level exchanges, which were in the Senate bill in 2009, are what we have. I think that in the end, that's going to turn out to be the strength of this law. Yes, 29 states have GOP governors, and most of them have got their attorneys general filing lawsuits to have this found unconstitutional, or writing letters to Kathleen Sebelius saying, do we really have to expand Medicaid to those people? She's writing back and saying, for the most part, yes, you do. Not entirely. She's strategically giving room to maneuver. Very careful in her decisions about waivers to offer the states or particular companies. But they may be complaining, but they're also taking the money to plan the insurance exchanges. I'll give you the example of the state of Virginia, where Ken Cuccinelli, the colorful, obstreperous, far-right Attorney General, is filed one of the cases that went and found the individual mandate unconstitutional and is now trying to get the Supreme Court to speed it up, which they will not do. He's there, but the conservative governor of Virginia has just taken all the money to do things like plan the Medicaid expansions and set up the exchanges. That's happening in all but 3 states. And it may happen in the final 3 if the Obama administration gets that judge in Florida to admit that he can't suspend the entire law or he's overruled in the higher courts. So the game plan, as I observe it, and I'm not an insider, is to get as many facts on the ground in the states as possible. And this law allows a great deal of room for flexibility in the states. So that in some states, somewhat more market versions can happen. In other states, I think it's even possible to set up a single payer, or at least a public option that could grow. Businesses, citizens groups can get involved at the state level, and they can do it in ways that are tailored to the different experiences. I don't think we need the Brown-Wyden bill, because there's a lot of room there in the state level process. And the key thing about the law is that it says to the states, you take the money and plan the exchanges and the Medicaid expansions, and if you don't, send us back the checks, which you may notice they never do. A couple of cases, but hardly any. And not the big bucks. They never send the big checks back. And if you don't do it, the law says the federal government can intervene to do it for you. And the Obama administration and Kathleen Sebelius have made it crystal clear, both in public and in even tougher communications in private, that if this doesn't move forward in the states, they will step in. And lo and behold, even the most Tea Party-infused Republican governors have suddenly discovered the need to move ahead with their own planning for the implementation of the law. So, bottom line is, I agree that it's going to be a high-stakes battle for the presidency in 2012. But if Obama is reelected, given the steady progress in implementation in the states, given the fact that employers and insurance companies are adapting to the new rules of the game, month by month, day by day, quietly, I think the law will survive in its basics if Obama's reelected. If he isn't, who knows? But even then, the uninsured are there. If there aren't federal payments to help states reimburse their hospitals and doctors for caring for them, what happens? It may be that even in the case of Obama's losing the election, many states and businesses will discover the merits of keeping pieces of this. I think the bottom line is that it will be 10 to 15 years before we will know what healthcare reform looks like in America. But I think the politics and the policy were fundamentally and permanently changed a year ago. It's just that we have to go through a great deal of struggles and pushes and pulling before we find out exactly how they were permanently changed.
So thank you. Wow, you gave me lots to think about. I am, unfortunately, an economist, so I know very little about the politics of healthcare reform, which is what Paul and Theda both talked about. I was really interested with the comments about redistribution, because on the one hand, there's the redistribution that we see There's a Medicaid expansion up to 133% of the poverty line. People under the ACA are now eligible for Medicaid. And if one is between 133% of the poverty line all the way up to 400% of the poverty line, one is now eligible for federal subsidies to purchase health insurance. So that's definitely a form of redistribution. The individual mandate that Paul talked about is another form of redistribution. It's a way to get redistribution from healthy people to sick people. It's also sort of an internality in the redistributive sense. It's a way to redistribute resources from me when I'm healthy to me when I'm sick, because I'm probably going to get sick in a couple of years. And so there's a number of reasons why I think both the individual mandate and everything we've seen in terms of making health insurance more affordable are redistributive. When I think about healthcare reform, though, I think about three challenges. And in order of sort of ease to kind of handle them, I think the first challenge is the challenge of uninsurance. So we've got people who are exposed to tremendous financial uncertainty every time they get sick. And the only way to sort of deal with the financial uncertainty is to expand health insurance. So this is just a sort of a graph of the number of the uninsured in the United States increasing over time. That's challenge one. But I think one problem in public policy is that we conflate health insurance with health care. And we often conflate health care with health. So just because we have insured the uninsured doesn't actually mean that all this redistribution that we're super excited about has actually resulted in them getting better health care. Now, don't get me wrong. I think this was the right problem to solve. So I'm in support of the ACA. But I don't think it was enough of a problem. Future legislation will have to move to the next problem, which is better aligning health insurance with health care, because health care is the thing that makes you well. Having an insurance policy doesn't make you well. On health care, we have a particularly bad record in the United States. So this is just one way to look at the record. This is a paper from the New England Journal of Medicine from a group at Rand. This is sort of the gold standard paper looking across 439 quality indicators in the United States. On average, Americans get 55% of recommended care. So we spend the most on health care. We certainly get only 55% of recommended care. By the way, the recommended care measures here are things that even economists know that you should get. So this is not sort of high-tech medicine. This is like, did you get beta blockers after a heart attack? If you were diabetic, did you get your HbA1c evaluated? We're clearly, despite all the money we spend, having trouble with some very, very simple things. And again, this piece of legislation, while it tries to get at quality, has nothing explicit about it on quality. This is an insurance expansion that was really long due, but it has very little on sort of concrete ways to improve quality. So quality, I think, is going to be the second challenge that the country will have to address. The third challenge that I know absolutely nothing about, but that's the hardest challenge to deal with, is the cost challenge. So the black line is Medicare spending on physician services over time. And so Medicare is growing at about 7% a year over time. The red line is the growth of physician services in our favorite area of Texas called McAllen, Texas. The blue line is what's happening in Miami, Florida. So this is a combination of fraud, waste, and abuse. In Miami, we think a lot of it is fraud. In McAllen, we think a lot of it is waste. This is something that this president was the first president to acknowledge, and we should applaud him for that. But this is a problem that very, very few people who've thought about cost growth know what to do about. We're good at measuring it. We're good at telling you that you should worry about it, but we know very little about what to do about it. But it is a challenge that we can't ignore in the long term. Medicare is growing at 7% a year. Incomes are growing at 3% a year. In the long run, this is a fiscal train wreck waiting to happen. So now you might say, hey, listen, I thought you were progressive, but you give me a very conservative message. I think as a progressive, we're not going to be able to give people health care of the type that we want to give when you've got the McAllens and the Floridas running around. Like, I think it's a challenge to actually sustaining a Medicaid expansion or a Medicare expansion if the quality of care is both expensive and low quality. One way to see that is this graph, which is data on 4,690 hospitals in the United States. This is the association between quality, survival for heart attack patients on the y-axis, spending on the x-axis. More doesn't get you better in the United States. And for those of you who have never seen zero before, the red line is zero. That's the regression line. At the state level, it looks like this. So if you actually plot quality of medical care received by Medicare beneficiaries against spending. This is what it looks like. The Affordable Care Act, again, like I said, does a wonderful job of dealing with the expansion in reducing uninsurance. It does very little about cost containment. I think most of the cost containment goals are largely aspirational. I hope they work out, but they're really not enough to sort of derail a train that's moving forward at 7% a year. So why are we having these cost containment problems? Well, one problem, this is a problem that Paul knows a lot about, is there something's gone wrong in medicine in the past 15 years. Maybe it had gone wrong earlier than that. But you see a lot of financial entrepreneurship by physicians. I write in the major medical journals, so the major medical journals think I'm a physician. They actually think I'm a urologist because I often write about prostate cancer screening. And I got this brochure from Siemens in the mail the other day. This is a urologist sort of staring off into the sunset. And the brochure from Siemens was pushing on me a multi-slice computed tomography machine, and it was telling me to capitalize on an imaging opportunity. So this was sort of interesting to me. I noticed that there was this exhibit inside which tells me if I were to run my multi-slice imager twice a day, 5 times a day, 10 times a day, 20 days a month, Medicare would reimburse me $220 a day. And that's what my return on investment would look like. So look all the way over on the right-hand side. If I ran it only twice a day, I'd break even. So that's no good. But if I ran it 10 times a day, I would make $2.1 million. So this is something that medicine was historically able to patrol somehow or the other. But they are no longer able to patrol internally financial entrepreneurship. And so we're going to need a lot more heavy-handed regulation of how these technologies are reimbursed or whether they should be covered in the first place. I think my favorite example of this is proton beam therapy for prostate cancer, which requires you to build a cyclotron the size of a football field. The thing in red is the patient. So the ratio of capital to patient is not accidental. This therapy, what it essentially does is you build your cyclotron, you accelerate protons at the speed of light and then shoot them into the tumors in the man's prostate. What's beautiful about this is that if you do enough PSA testing, you can find lots of men with prostate cancer. So you've got an unlimited reservoir of patients that you can bring into your cyclotron. We have no idea whether this technology works. It costs $100 million. And we're now on the verge, the major specialty societies are petitioning that this technology be covered. If we as a country decide to fund this kind of technology, it is the end of the Affordable Care Act. We cannot expand healthcare benefits, valuable, much needed healthcare benefits, if we're also affording this kind of technology. What we need is, we could zoom in on the patient inside the cyclotron. That's what he looks like. What we need is a way to make sure that the social insurance programs are doing exactly what we want them to do, which is deliver prevention, deliver care, not just catastrophic care, really valuable care for patients who are suffering from diabetes and congestive heart failure and heart attacks. But when you've got a physician running a Somatom machine 10 times a day, or the Massachusetts General Hospital building a cyclotron, I don't know if they are, but I wouldn't be surprised if they are, somewhere in Beacon Hill, we're going to have no money to provide the vital protections of health insurance. So what does the Affordable Care Act do about this? It does exactly what we don't want it to do. So here is language from the Affordable Care Act that forbids Congress from using costs to decide whether a therapy should be covered. So it's not just that we did nothing about costs, it's that the Democrats felt so compelled to respond to these charges of, your rationing care that we put in language into the bill that really sort of, handcuffs our ability to do anything about the cyclotron and the Somatom machine. So what I worry about in the long term, once the debates about, the individual mandate and all are wrestled is, look, I think healthcare is a wonderful thing and we have to give it to everybody. But I just worry that in the absence of having a very difficult conversation about whom to cover versus what to cover. So we in the US are very good at saying, let's give healthcare to everybody, without being able to draw the line on what kinds of therapies we're not willing to cover. What we've done is essentially created an environment where physicians are able to use patients' bodies as ATM machines hooked up to the US Treasury. You know, that to me is not genuine reform. I think we were right to do something about insurance, but I think in the absence of dealing with quality and cost in the years to come, these debates about, you know, what are the politics, what do the Democrats feel, what do the Republicans feel, these are important in the here and now, but as a civil society, all of this is going to evaporate unless we deal with the somaton problem that's waiting for us. So why did this all happen? I'll tell you what, I'm going to take my crack at political analysis, and this is something you shouldn't do at home in the presence of these two guys, but nevertheless, my theory on this is that this is genuine naivete by the Democrats and by this administration. On the one hand, this administration, in each of my dealings with them, knew more about health care than any other group of people, including the Harvard economists who were advising them, which was wonderful. But I think in Washington, stories are substantially more powerful than statistics. And so the mistake that they made was, in some sense, they decided to deal with the hardest problem first, which is the cost problem. And that got them totally derailed. I don't think that this is a group of individuals that are particularly good at communication. Theda, you alluded to this in your comments, and I'd love to kind of get you to talk about this a little bit more. I felt very much that we should have been talking about the 11-year-old boy whose mother died because of lack of health insurance to make the case for the insurance expansion and deal with the cost problem in this sort of sequence that, you know, once you deal with health insurance, the next problem to deal with, again, is not cost. Let's deal with quality. There's no pro-low quality party out there in the United States. So let's deal with costs. Let's kind of improve, let's deal with quality. Let's do something about quality next. And once we've done something about quality, it's a lot easier to have a conversation about, hey, given that you are a low quality provider or a low quality area, why should we be paying you the same as a high quality area provider? So I think that's the way I kind of see it. I was very, very disappointed that the president and the administration just didn't see this sort of opposition coming. I think lots of people would have said that most people really don't understand how healthcare is financed in the United States, and any conversation about cost, no matter how necessary, is going to result in this sort of protests. And so I think this is the reason that the Act, while increasing in popularity since it's passed, is really not as popular as it should be. So I don't know what to do about this problem now that it's out. But my advice as an economist is to say, hopefully we will bumble our way through the individual mandate, and then next we'll probably turn to the quality debate. And finally, in many, many years, once we've measured quality, it's easier to do something about costs. So those are my thoughts on the challenges that face us. We have, let's see, I was asked to wrap up. We have a bunch of time to talk about a number of things. I have questions for you and for you, Paul and Theda. So let me ask you each a question, and then I think the audience is itching to ask you lots of questions, and so we'll move to that next.
We should get the audience in here pretty quickly, I think.
You want to go to the audience first?
Well,
how do you feel, Paul? Well, let's go to the audience. Hey, listen, I can wait. I can do this online. In the back. First question.
You're taking up all the time.
It seems to me that three unfortunate factors argue in favor of the Healthcare Reform Act becoming more and more strengthened. That is, projection of job unemployment being continuing for the number of years low, and real estate prices lower, or staying the same or lower, in fact, and also associated with that, the bankruptcy that results from not having health coverage, plus other factors that feed into bankruptcy. Those things seem to be arguing for the healthcare reform to be more and more take hold.
Well, I think if we were all reasonable, that would all follow. That people would see that unemployment leaves people without health care, and that reforms that provide health coverage, even when you're unemployed, are a good idea. I think if we were all reasonable, that would be true. Unfortunately, we're not all reasonable.
In the front over here. Sir.
Wait for the microphone.
I would like both speakers to Paul Starr and Theda Skocpol to comment on this fact. The health insurance industry was persuaded by Obama to sign on to the Affordable Care Act, and the reason was that the Affordable Care Act had a mandate and assured the health insurance industry of a greatly increased market. Now, the health insurance industry probably has the most powerful, effective health care lobby existing. Why do you all think that the healthcare lobby's interest in maintaining the mandate will not be critical in determining what happens? My guess, for what it may be worth, is that the Supreme Court will listen to the demands of the healthcare industry and will be in favor of the mandate. Point number two. Dr. Chandra, you were right in putting your finger on health cost as being a critical problem. It seems to me that we have to ask ourselves, why is health care so expensive? You alluded to it. It's because of the way we pay for health care, because of the economic incentives for increasing volume. No amount of price control, no amount of so-called quality regulation from the outside of the medical profession is going to change the fact that now doctors and hospitals do well, they survive by providing more expensive services. Until you change that, you're not going to solve the problem. How do you change that?
Let me ask Paul to talk about the individual mandate and
So for those in the audience who don't know, this is Dr. Arnold Rollmans, the former editor of the New England Journal of Medicine. And so the reason for the mandate is not just that the insurance industry wanted it. The reason for the mandate is that without some device, like the mandate, as I said, it doesn't actually have to be the mandate, but without that device, the premiums would be substantially higher, the subsidies would be substantially higher,
That's
and
obviously true.
It wouldn't work. It wouldn't work. So now, as it happens, by the way, the insurance industry did not support the Affordable Care Act. They never endorsed the legislation, and I tell the story in the book that I'm writing about all this. The five largest insurance companies spent $80 million through the Chamber of Commerce to defeat it. And they, the big five, the for-profit insurance companies, have set up a new organization, and they are in favor of repealing it. So it's not true of the insurance industry as a whole that they were behind it. But you know, there's a good rationale for something like the mandate, if not the mandate itself.
I'd like to comment on the point that you suggested, that going forward, there are going to be tensions within the oppositional coalition having to do with the mandate or the mandate substitute. Paul's right that the insurance giants did not support this law. The deals, Larry and I talk in our book.
Well, they
about,
did, but
wait a minute.
Okay.
Let me answer. They really didn't. They were kept at the table and kept from going all out against it in an elaborate game of delay until fairly late. But the deals were struck with the hospitals and the pharmaceutical companies. The Obama administration played a divide and conquer game with the major players who, if united, could have lobbied Congress to stop this thing cold. But it's very important to keep in mind that the politics that leads to a law is not the same as the politics that comes from the law. I don't agree that the insurance companies are all in favor of repeal now. I think they're playing a double game.
So do I.
I think they are contributing to the GOP, either on the off chance the whole thing goes away, or much more likely, what business interests want is, in the deep of night in a congressional committee, changes in this, that, and the other thing, the quiet evisceration that will change the law in directions they like. So they're investing in that kind of GOP power. But some of the major insurers have come out saying that they don't want the mandate to go away. And at the political level, as opposed to the lobbying level, I mean the electoral coalitions that are there in the Republican Party, the Tea Party crowd and the insurance company crowd will come to blows on the matter. Because the insurance companies could be left with the popular insurance regulations without the expanded customer base. And they know that. I mean, it's so tempting in meetings like this to act as if it's a conversation or an analysis. Yeah. It's not. It's a political battle, and it need not lead to any kind of optimal outcome for any actor. Yeah.
Certainly, if you listen to Karen Ignani, who is the spokeswoman for the health insurance industry, she has very clearly said that she will support, their industry will support it with the mandate, but not without. But I agree with you. They're playing a double game. They're working both sides of the street. Let me just make this one other point, and then I'll stop talking. The cost is really the heart of the problem. The Affordable Care Act just pays lip service to solving the cost problem. It does not really solve it. It talks about accountable care organizations and paying for quality rather than blah, blah, blah. Good ideas, nothing, no hard. The Congressional Budget Office knows that there's no reliable control of health care costs in that act. And all the best predictions are that the health care costs will continue to rise unsustainably unless we do something about it. It seems to me obvious what has to be done, and that is to somehow, by some means, get the medical profession to sign on to a new way of doing business. Replace fee-for-service with salaries, replace silos of individual private practices with group practices, set budgets, and finally, ultimately, get rid of health care, of private health insurance. Private health insurance contributes nothing of value at all comparable to their cost.
Thank you. I saw a bunch of hands go up over on this side of the room, so why don't we take a question all the way in the back?
Thank you. I especially appreciated the last speaker's main comments, but my questions are, I have two questions. The first is about the individual mandate. I remember Obama talking about it, and I remember one of the reasons that I had a preference for Obama over Hillary was because of his position. I'd be interested to hear what you think was going on. I think you touched on it a little, what you think is behind the mandate. What do you think was going on there with a candidate who says, I'm not for this, and then later on is passing legislation that includes that? Was he dissembling when he said that he was against it in the beginning, or, you know, who got to him?
CBO. I'll give you 3 letters. CBO.
And he didn't know about any of that when he was a candidate?
You don't get anything through the Congress of the United States in the budget-constrained situation we're in unless the Congressional Budget Office costs it out as saving money over time.
And he didn't know about the CBO when he was a candidate?
I don't think he knew about he wasn't thinking about the design of the law, nor should he have been. in the election.
Well, I'd be interested to hear, but and the second thing has to do with who, I mean, some people say, well, the constituency for this is going to grow. What I'm wondering about is I didn't see much of a I mean, in terms of just ordinary citizens, I don't see who, where, or what the political or social base for this legislation is. I don't see it. Maybe it may grow in some of the ways that Theda
Two-thirds
suggested.
of Americans like all of the parts of it except the individual mandate.
But, well, I think that's pretty significant. But what I'm
Well,
wondering
not
is,
really.
our insurance, I'd like to hear a little bit more about the insurance companies being strengthened structurally in the political system as a result of this legislation. There seems to have been a disagreement about that. But weren't the insurance, wasn't there a pledge to deliver $175 million in support for this legislation? Was that just the pharmaceutical companies and the hospitals?
The pharmaceutical companies.
Right.
Pharmaceutical companies.
Right. It wasn't the insurance companies.
So I don't want to spill I'm finishing a book on the whole struggle over health insurance going back to the early 20th century all the way through the most recent developments. And I don't want to spill some of the details of that book about what happened inside Obama's campaign and in the White House and just when he seems to have changed his mind on the individual mandate. But he changed his mind before he was president. And there are a series of reasons why I think he did at that time. But I think, in fact, it was a great tragedy that he went from a position which in the primary campaign was, I think, good politics.
Hillary Clinton won the Pennsylvania primary.
Yeah, but it served it served Obama very well during the primaries in positioning himself as being the more moderate candidate, that he wasn't in favor of the mandate. It was part of a whole appeal that he made, that she was one of these bossy women who wanted to impose controls and so forth, and he was more relaxed, that easygoing, no mandate, you know. I mean, it really, it fit a whole appeal that he had during the primaries. I think it was very, very successful in attracting votes. But so he went from a position that I think was good politics, but really bad policy. The position he was taking was not defensible at that time. He was in favor of all these insurance reforms and no mandate, and the result of that would be very substantially higher premiums, and he wasn't owning up to that. So he went from a position that was good politics but bad policy to a position that I think is a better policy but bad politics, without ever figuring out a position that was both good policy and good politics. That's what's been missing.
The only problem I have with this analysis is that the Obama administration didn't design the Affordable Care Act. It wasn't the 1,342-page thing that Clinton shipped off to Congress. This was shaped in key congressional committees, and probably the most important of all was the Senate Finance Committee.
So Theda, I have a question for you. When we hear the president talk about the Affordable Care Act, he often talks about jobs and American competitiveness and its effect on the budget deficit, and he might talk about prevention and costs. But it seems like what it does is it reduces medical bankruptcies. It reduces financial uncertainty. That's a wonderful thing. Is that just, again, is that an example of if you talk about those things, that's just bad politics? Or do you think that this was a genuine communication failure about where this piece of legislation is most valuable?
Well, I don't agree with what appears to be the consensus here, that there are no useful cost control ideas in this act. And I want to say something about how cost control works historically. There are a series of incentives explicit in the law to encourage new payment schemes. There is a Medicare board that's quite important and quite contentious.
But can't use costs.
That they stuck with. You know, don't get carried away by the sentences. Think about the structures. If we go back and look at the history of Medicare, Medicare expanded coverage for the elderly in an incredibly inefficient way, with all kinds of payments to hospitals and doctors that were outrageous to get it done. And that's when liberals were liberals. I mean, no hope now for anything. So you don't get things through the Congress of the United States. And I'm so struck. I go to Tea Party, talk to Tea Partiers in Virginia, and they know the details of Congress. In liberal Cambridge, we always act as if a speech by the president accomplishes something. Nothing happens if it doesn't get through the Congress. And the Congress is very sensitive to all these vested interests that are, the costs are profits for them. So we have to look at what comes next. Once you get everybody or almost everybody into the system, and you put onto public and institutional budgets some of the rising costs in a way that they can't handle by simply saying, well, we're going to dump those cancer patients or those people with the breast cancer. You change the rules of the game. That creates the possibility for institutions ranging from government to hospitals to state governments, above all, to start getting serious about cost control and the new payment incentives that Dr. Wellman is right are at the core of the solution, the payment process. You're going to see, just as we did with Medicare, after a period of expansion of coverage and rising costs, suddenly they started getting more serious about cost control. That will happen here if this law is not eviscerated, which it may be.
That's right. I think it would be absolutely correct to say that maybe this piece of legislation doesn't do anything about costs, but what it creates is a number of institutions like the Medicare Independent Payment Advisory Board that tomorrow could be armed with teeth. In some sense, ensuring the uninsured hastens fiscal Armageddon, so the need to arm it with teeth will come sooner as a result of the expansion rather than later. And that revitalized institution 5 years or 10 years from now might do a lot. If that's the reason that I should be excited about the cost control measures in the ACA, I absolutely am. And I'm actually one of those people who thinks that we should have started with insurance and not dealt with costs at all, because I think costs just derail. The conversation about costs often derails all the wonderful things in this institution.
I must make one point that I've been a physician for over 60 years, and I've seen the practice of medicine change. I've been personally involved in all aspects of medical care. One overwhelming truth is I've learned from 60 years plus of being a doctor, and that is there is no sensible, satisfactory way to control the costs of health care except by changing the behavior of physicians.
Yeah,
there are a million
that.
different ways that doctors who really make the decisions can be influenced, and that controls healthcare costs. Now, the only way to change the behavior of doctors is to address directly what are the incentives, what are their needs, what drives them.
Yeah.
And it's obvious that fee-for-service drives the system.
Can I just say one thing, though? I think
the administration, I wrote a piece in the New York Review of some months ago, in which, over a year ago, I guess, I said, I'm all for expanding coverage. I'm all for all the good things that's in the Affordable Care Act. But you have to consider how to control the cost, and that act did not do that because it put everything that wasn't.
Sir, I totally apologize for cutting you off. I see lots of hands, so I want to give other people a chance. Yes, ma'am, in the back.
So I guess my question is where do consumers fit into all of this? So, for example, why is it that we just don't have a choice of where we go for our care? Why is it that the contracts that insurance companies have with hospitals, they're just private policies? And I think that's one of the biggest problems, is that people don't really understand their insurance because it's so incredibly complicated. And, you're tiering doctors and, and it's just an entire marketing ploy of where you're sending your patients for respective care. And you're sort of like with the new medical home models that are coming up in Massachusetts, you can see how community health centers are being aligned with certain hospitals. And it just seems that consumers are really getting shafted in the process. I'd just like some commentary on that.
I think consumer groups should pay very careful attention to the creating of the new exchanges, because there's a lot of room for states to do things about transparency and the range of choices people will have, including, by the way, if the state's politics or the region's politics allow it, creating a public option. So forget about all that stuff on CNN and pay attention to what's happening in your state capital. Would be my advice.
I mean, personally, I think that choice is a little overrated in a lot of these markets. I think there's something we have it in our head. I mean, maybe it's something we've learned in economics classes that, 20 types of toothpaste are better than 5. As an economist, I have some obligation to say that. I think that's a true statement. It's not clear to me that that's actually true in healthcare, because a lot of these decisions are made in the hot state of the world. It's not like patients have all the time to shop around. Personally, I think a lot of people say, if I had a network and I understood what the limits of that network were, I would be okay with that choice. In Medicare, for example, you have an infinite network. You could basically go to any provider in the world. Medicare is not working, it's hemorrhaging. So it's not clear to me that more choice is actually the solution to any problem in healthcare. I would actually advocate less choice. As long as it's good choice, it's okay.
Medicare controls costs better than private insurance does.
Well, I think that's because it piggybacks a lot of the quality measures that private insurance does. So for Medicare, all the anti-fraud is working through.
The innovation went the other way.
How so?
A lot of the innovations in cost control started in Medicare and went to the private sector.
Like the prospective payment, for example. No, absolutely. But I'm saying, like, in terms of techniques to fight fraud, waste, and abuse, Medicare doesn't evaluate claims with the same frequency for waste as the private insurers do.
Medicare is able to control price. It doesn't control
I think you're wrong about that.
That's right.
And I think expanding Medicare is a way that I'd like to see this whole thing go in the future, but we're not going to get there for a while.
No, but I think we could expand Medicare to improve things. I guess my point is the way to expand Medicare and sustainably expand Medicare is not to cover everything. Is to actually have a very difficult conversation about...
Well, Medicare doesn't cover everything.
We mostly do, right? That's the whole problem with Medicare.
They don't.
It becomes very
That's
hard.
That's not true.
The cyclotron, if I want...
Do you have evidence that cyclotron is actually being covered?
No, but I can give you evidence that Medicare will cover 5 cardiac MRIs in a week without asking, why did you do it? Right? The McAllen, Texas problem is a Medicare problem. It's not a non-Medicare problem. The Miami, Florida problem is a Medicare problem. Again, it's not a non-Medicare problem. Medicare doesn't ask the question, did this patient need an angioplasty for stable coronary disease? It never asked that question.
They're actually increasingly asking that question, and I think they've done more than private insurers.
I think that's just not true.
The most privileged people, like those sitting in this room, we have access to more costly stuff than all Medicare patients probably do.
Yeah, my point is we can do a lot. If you want to expand Medicare, we can do a lot better by making Medicare more valuable. That's all.
Well, of course we can, but we'll have a better chance because at least it's a big market.
Yeah, I think what Medicare does, though, is, Paul, you said this, Medicare sets prices, and I think that's a very weak lever to get the right amount of stuff done. Because if I were to cut the reimbursement for a certain procedure, say it was that multi-slice CT, I worry what doctors could do is they could say, look, the reimbursement fell from $220 to $180, I'll just run it even more often. So the price lever is a very blunt lever, and
so
that's essentially...
you got to move to more kind of accountable care groups.
Yes, exactly.
But this law does encourage that.
This law...
You can all say it's not perfect, but what else do you got out there that could have gotten through the Congress of the United States?
I saw a hand, yes.
So, just to speak, if I could, to this point, the CMS has for many years now been engaging in comparative effectiveness research. And one of the things that's inherent in the idea of comparative effectiveness is cost effectiveness too. It's not always right there up front, but it is just implicit in that. CMS can't do it itself sometimes, and so it contracts out to AHRQ, which contracts out to universities, and so on and so forth. This is something that is being done, and what the legislation says is coming after the fact. It is giving sanction to something that is already being done. There are times now when Medicare is able to say, no, they won't cover these things. My file is getting a little bit bigger on that sort of thing. It's not happening as much as we would like.
It's going to get bigger and bigger because the politicians are going to have an incentive.
Medicare is saying no. And, you know, if I can just go back to a point that you actually made before with regard to and actually you did as well. Why isn't cost control in this piece of legislation? I think it is implicitly, as Theda said, with the comparative effectiveness, innovation research, you know, a few things like that. It is patient-centered care. It's got the medical homes and all that kind of thing. I would give the example of what's been happening in Massachusetts. Massachusetts explicitly set off with, let's get coverage first, and let's not tackle costs because it is such a politically challenging issue. But look, it's not been that long. I mean, I think it's amazing that in 5 years, what's beginning to happen, and Patrick is beginning to talk about bundled payments. That is actually, I think, quite revolutionary, and that has happened in 5 years. So, you know, the point is, and I think they would agree with the time, just start the thing going. Implement it, get it. Incrementalism is something that actually has worked in the U.S.
Other questions? Yes, in the back.
Different subject. My question is for Professor Starr about your 5-year lock-in plan, alternative plan for people who would opt out instead of the mandate. I wonder what you know or what you think about popular psychology about that, whether you think it might be equally unpopular. I mean, listening to you talk about it, I just wonder whether either people might say it's coercion that amounts effectively to the mandate anyway, or what about people who might legitimately change their mind after putting pen to paper? Is it fair on them?
Well, it allows people to opt out without any penalty. And in that regard, it means that it's not a mandate. It would have, I think, probably obviated the Supreme Court challenge to the law. It would have allowed politicians to say, hey, you know, when they hear people saying that they don't like the mandate, look, if you want to opt out, you can opt out. You can't, however, just allow people to opt back in whenever they want. If you do that, then you're going to have a lot of free riding. Premiums will go up. So you need some device to limit that. And you know, this is one way to do it. Maybe 3 years is better. Maybe 5 years. Now, when there would be a market for insurance for which you can't get a subsidy, and which would have pre-existing condition exclusions, effectively what it would say is you're opting out of the new world created by reform into the old world that existed before.
And that didn't work. And all we have to picture is some sympathetic person who opted out, and then they suddenly get cancer. That's not going to work. I'm sorry. It's just not going to work. But you know, I'm actually very curious, and I'll ask Paul.
Look, there are going to be millions of people uninsured under the law. Okay, you're comparing it with in your mind with an ideal where everybody actually is insured, but the law doesn't actually achieve that. Okay, there will be 20, 30 million people, even under the CBO projections, who don't have insurance. And actually, because I think the compliance with the
not American citizens.
Because the compliance with the mandate will be lower than what CBO expects, I think the number will be a lot higher.
Well, all right, but here's what I want to know is what evidence do you have, Paul? Because I must say, I've studied the public opinion polling on this very closely and think about the political process. I don't think the popularity of this law is what is endangering its survival for the 5-year period. Yeah, it's not wildly popular, although it's wildly popular when you get to the specifics. And what we're going to see going into 2012 is President Obama talking about all the popular things concretely, and the Republicans yelling Obamacare, government takeover, death panels. There is no need for it to be true. I mean, I just got back from Virginia where we were interviewing Tea Partiers, and two things were very striking. One, they were having a debate on their website about the 3.8% real estate tax that is in Obamacare to fund health reform. Now, there's nothing to that. It's not true, but it's a very powerful political mobilizer. And I had a physician in the Tea Party tell me in great detail about the public option that was in Obamacare that was going to systematically drive the insurance companies out of business. She was giving the Jacob Hacker analysis and saying it was in the law. I'm sitting there thinking, if only my liberal friends in Cambridge believed this were true. So let's not kid ourselves. It's not the facts of what's in this law that are behind the concerted, hysterical political campaign against it. It is the fact that even if it disappoints liberal Cambridge, it will change the rules of the game for profit-making entities going forward, and they don't want that. They're going to fight very hard, and they're not going to fight about accurate things. If one thing goes, other things will be found, until we see whether this thing survives enough to get some traction. And then you'll see businesses suddenly discover that they can live with it, as they are quietly already doing. You'll see state governments decide that, yes, they'd like even more generous Medicaid subsidies. And in fact, Medicaid will become a more national program. And the insurance mandate may or may not get fiddled with in the ways that Paul thinks are wonderful, but it won't happen before we decide whether this thing is going to survive, because the opponents are not going to allow that to be modified before the end game of survival is clear. It's a political tool.
Yes, ma'am.
If you can't inject facts into political discourse, where is the discourse in this country going to go?
It's very troubling.
I mean, it just astonishes me.
Well, you know, there was no death panel in any version of this bill. And
I had another person in Virginia explaining to me about the death panel.
Yeah, I mean, that...
The real estate tax is amazing. Where does that come? That's out of thin air.
I mean, that one you can't even find a couple of words somewhere in the law that would give you the idea. But that was being confidently discussed as the latest horror.
Other questions? We have 3 minutes before we wrap up. Did I see a hand? Sir, you've had a turn, so let me just see if there's someone else that wants to go. Yeah, over here.
So I definitely have not been practicing medicine for 60 years, but I'm a physician also, and I wanted to comment on some of the, or actually, I'm surprised, and I wanted to see what you all thought, that there is not a physician education aspect to this, because, you know, we're talking about the consumers, we're talking about the healthcare industry, but in the end, it's the physician who needs to be sort of retrained. And case in point, I was taking a bus from the Longwood medical area here, and I overheard a couple of Harvard medical students talking about their emergency room rotation and how the most important thing is to learn how to page other providers from the emergency room, and that's the key to do well in the emergency medicine rotation. And so these are, you know, second and third year medical students, and I think if we don't retrain physicians, because there's so much algorithmic care that is sort of, dictated by private organizations, actually, that, you know, dictate this, whether it's, you know, changing the management of diabetes, how you determine whether somebody's diabetic or not, to, you know, when you check thyroid numbers for patients. These are all dictated by actually private industry or private entities, not like the UK, for instance. So I'm just curious if I'm surprised that there's not a medical education part of this
But it's
law.
I guess we would say, and I'm curious about the panelists, but I mean, it was designed to expand insurance, and it was designed to make insurance more affordable, and I think lots of people would have liked to put lots of things into it, and that's an incremental process, and we'll get there, because I think quality is the next thing that the country takes on. But I don't know, Theda, Paul, would you like to add something? Okay, so we are right on time, so I'm very, very pleased. Thank you all for coming, and thank you to our panelists.